Hey, what's up, guys? This is episode 45 of the Man of Mastery podcast, where we're putting purpose and passion into action, where we embrace getting out of our comfort zones to grow, and we stand ready to learn and ready to lead in service to others. Now, this is really timely. Service to others. This past week, of course, COVID was officially designated as a pandemic by the World Health Organization, and I think we're all scrambling to get our heads around it and what it means for a period of time. Schools are canceled, travel perhaps curtailed, restaurants closed, offices working remotely. So I held off for a few days on getting the weekly episode out on schedule. I wanted to track down someone I could bring in and just pick his brain to understand more about what we're facing. So this is a guy whose purpose, his passion, his profession are all about service. Dr. John Nichols is a medical doctor in Utah. Now, he's an OB-GYN that specializes in working with high-risk cases. In other words, moms and babies who could be in the high-risk category for COVID. And so he's doing his best to stay on top of information, facts, and developments. Now, he's not a doctor that specializes in viruses, but he certainly knows a lot more than I do and probably most of us. It's also notable that he's an osteopath, meaning that he takes a very holistic view of health and medical treatment. He's also a just all-around super smart guy, a trusted friend, and he's a fellow coach. So I really appreciate his taking time out from his patients and his practice to come spend a little time here, share more about what we know, what we don't know, and what to do about it. And to let you know in advance, the show notes from this one can be found at manofmastery.com/045, where I'll sum up what we learned. And that being said, let's jump right in with Dr. Nichols and get an update on this COVID-19 situation. All right, hey, today I've got a special edition coming out. I know we've all got a lot on our minds, stress, worry, concern, questions about this craziness, the crazy new world we live in with COVID-19. So today I have the honor and pleasure of being joined by a friend and teammate, Dr. John. John, can I say your last name?
Sure, that's fine.
Okay, Dr. John Nichols, welcome. I appreciate it. Thanks for taking time.
Yeah.
So this thing is, I've got so many questions, and I appreciate you letting me pick your brain and figuring out what we can know, what we can do about this thing. So just to start with, maybe we hit what we know, what we don't know, and then start talking about things like containment, what we do as a society, and what we can do as individuals to stay healthy physically and mentally through this thing as a community. So this is the novel coronavirus. It's COVID-19. Does that mean there were 18 before it? Is this another variant? Is this like another evolution of SARS? Why is it COVID-19?
A very good question. Let me back up just a little bit. I'm a OB-GYN. I work with high-risk obstetrics, so I'm not a virologist, but because of the nature of what I do with pregnant women, they're more vulnerable to viral infections, and so I'm kind of on a frontline doc, so I will give you the information from the way I understand it, from being someone right in the middle of it and kind of in the infantry. So the guys I work with are some of the experts in the world. So I'll just kind of pass on what they're passing on to me and what we know and how to protect our moms and babies safe.
I appreciate that caveat, and I would even expand it a little bit. This isn't supposed to be prescriptive or predictive. It's just like you said, you're on the front line, so you're probably getting some information. But people should really listen to the CDC and their local experts. But any knowledge you've got is much appreciated.
Exactly. So just a little bit on viruses. Viruses are like anybody like us. They all have a family and a last name, like the Smiths or the Jones or whatever. And so there's within each viral family, there's different actors. And so the COVID-19 is within a family of viruses, and that's how it got its name. They identified it, and then they give it its name. So it comes from the COVID family, or the SARS. It's part of the SARS family. And so the COVID-19 virus that's exactly right. You're spot on. That's how it got its name. So it's within that same family of viruses.
Same family. Okay, gotcha. Mm-hmm. And just this is probably way beyond my scientific knowledge, but I remember from somewhere way back at school, we talk about DNA and
Mm-hmm.
We got DNA testing and genealogy and all that stuff for ourselves. And then we talk about RNA. And so I read something about the RNA of this virus, and that this virus actually mutates pretty frequently every 2 weeks or so. Is this sort of like you hear about people getting the annual flu vaccine, but there are so many variations of it? The vaccination covers some percentage, but there are these different mutations. Is that the idea of how
That's
this thing changes?
exactly right. Yeah, they can. So the COVID family is actually the cold virus, or it can fall within that same family, might cause the common cold. Then influenza is a different viral family, but actors are very similar. And you're correct with the DNA, RNA. There's different viruses that have DNA, and then there's some that have the subset of DNA, which is RNA. And so an RNA virus is it's just got RNA as far as its genetic makeup. And how it works is a little bit differently than a full stranded of DNA type virus. So,
Okay. So let's not jump too far into the won't we ever get a vaccine for this thing? But when you have something that mutates, is it really ever possible to have a widely effective vaccination program?
well, you could look at the flu vaccine as an example of that. The reason why we have to get the flu vaccine yearly is because it mutates. Um, but yeah, we can have a vaccine for a particular virus that we think is coming through, but again, that'll change as the virus mutates. So we'd have to come up with different viruses or different vaccines as it changes its structure and how it functions.
Gotcha. And if this thing is mutating every 2 weeks, is that more frequent than like an influenza?
Yeah, that I haven't read that, but yeah, just common sense would say that this thing's mutating pretty quickly. Can we build a virus? I don't have an answer for you. I don't know.
Okay. Gotcha.
I,
All right. Well, let's jump to some of the numbers. I think we all kind of hear. So, we start hearing numbers out of China. I don't know if anybody believes anything out of China. I think we're trying to listen to CDC numbers as far as transparency and accuracy. I mean, maybe some things are getting downplayed, but I think the mortality rate is running around 2%. And then is that right? Is that what you're hearing?
That's what we're hearing from the CDC. It's age dependent. There's been some things that I read articles today that were saying it's anywhere from 1% to 5.5%, 6%. And again, you look at the different countries and why are they seeing different mortality rates has to do with the mean age of the patient that's getting sick. So there's certain countries like Italy that the mean age is in the 60s.
Right.
And Korea, so they're seeing a higher death rate, where Korea was much younger, so they didn't see the high death rates like we saw in Italy, or we're seeing in Italy. So that kind of explains the approach that our government is taking, is because we have so many in the higher age group that's the age group that's most vulnerable.
Yeah. Okay. Let's talk about that a little bit. I mean, I did not know that about Korea's age skew, but I do know that they have been they've mobilized very quickly on responsiveness of some things like testing much more broadly than we have here so far. But so I did know about Italy skewing to the older. There's also a big smoking population there, as well as in areas of China where the air pollution or air quality is so bad, it's the equivalent of smoking. So we know age. We know things like smoking or maybe other respiratory ailments. What other
Correct.
things are risk factors?
Risk factors besides age would be someone, say, that's immune compromised. If you were an HIV patient, if you had like say a rheumatoid arthritis or lupus or some autoimmune disease where they're putting you on medications that put you in a compromised or immune suppressed states to control your disease. Someone who's a transplant patient, someone with diabetes, someone with hypertension, morbid obesity, smoker, those types of people that just aren't in good health.
Right. Okay. Yeah, I think you hit on my list there. I had obesity, diabetes, respiratory, and age. Hadn't thought about the more just broadly immune compromised. So there was a conference call and/or article, I think yesterday, from Goldman Sachs, and what I believe they said, to paraphrase, is that they've modeled, or somehow they've come up with, a number of 150 million Americans ultimately getting infected, And at that 2% rate, you figure 3 million deaths. But the way that they, I don't know, spun it, maybe that's the wrong word, is they go, okay, look, we have about 3 million deaths from, old age disease in this country on average per year. So these are sort of the same 3 million people where something is going to, kind of tip them over the edge, whether it's pneumonia from some other cause or some other infection or whatever it is. So they're basically saying it's not the 3 million that we lose every year plus 3 million more to COVID, that COVID may be the 3 million and we may not see an increased death rate overall for the year. Have you heard that?
That's an interesting way to do the numbers. No, I didn't see that press conference or that review. I didn't read that. That's an interesting approach. I'd have to read it to learn more about it. But yeah, I don't know how to comment that. It kind of makes sense, but it kind of doesn't. And we can probably get into that a little bit later when we start talking about why we're doing what we're doing.
Yeah. Let's hold on to that, because I think one of the things that I don't understand about those numbers is when you get to 150 million, which is almost half the population, sort of what happens at that. I would think it'd be a tipping point, but we can talk about the math and how it spreads a little bit more. Let's just maybe we talk a little bit about what we know about how it's transferred or transmitted.
Yeah, that was a big question for us till about a week ago. We thought it might be aerosol, which means if you cough, it lingers in the air. And then if you walk into that cloud where someone just coughed, you might get you'd be exposed to the virus and then be inoculated. We now know it's droplet. So we initially were being trained on these respiratory masks that as healthcare providers we were having to wear that would seal to our face. Now they're figuring out that if you need to wear those masks if we're doing some type of respiratory procedure where the patient's having to do deep breathing and coughing and the cough up sputum. But as far as wearing a mask, they're now being told that it's because it's droplet, we can just wear a normal surgical mask. So people that would need to wear a mask would be someone who is known infected or suspected infected, or a healthcare worker, or someone within 6 feet of that individual. You also need to wear eye protection because it can be transmitted through the eyes. But again, it's droplets. It's picking up those droplets and getting them into the respiratory system. So it's a little bit harder to catch than what we thought, but it's still very easy to catch.
Okay, gotcha.
It's not as easy as we thought.
So droplets versus, what was it, aerosol?
Aerosol. So an aerosol would be someone coughs and then it just lingers in the air, and then you walk into that cloud that they coughed into, you just got infected. A disease that would be equivalent to that would be TB or tuberculosis. Okay. So that would be something that that is very easily spread through closer contact. So
and droplets, I would think, could still be quite small. This is, somebody doesn't have to spit in my eye or right, lick my hand.
No, droplets is it means that the mucus is in a more of a liquid. It's in the mucus. It's but no, it's not. No, it's not a big chunk of somebody to spit in your face kind of thing. Like,
okay, and how about, so we hear about social distancing, the 6 foot rule. So what about across an inanimate object? Cell phones after I've touched something else, or the groceries I pick up at the store, or the Amazon box that gets delivered.
Yeah, those are all excellent questions. I was listening to the CDC report on Friday, and they've done some testing on inanimate surfaces with just the pure virus. And they were quoting a 4 to 6 hour life of the pure virus living on a surface. In other words, you take pure virus, lay it on the surface, come back every hour and then culture it out and see if it's still there or still alive. The interesting thing about viruses is when someone coughs or sneezes or breathes, it can be covered in a little bit of a protein, mucus, and that can land on the surface, and that actually helps protect the virus. So I read today that they're saying that 4 days, 6 days, it can live on a surface, maybe even longer. So that's why we're encouraging people to not only wash your hands frequently, But when you're going to touch an inanimate object, wipe it down with, your wipes, your sterile wipes, and like when you go to the store, wipe down your cart, that sort of thing. So I guess potentially it could live on an Amazon box if it was several days. Probably not. We know that it's heat sensitive, so if it was in a, if you live in an area that the climate's really hot, the virus is probably not going to survive in the hot car. In the summertime in Phoenix, it's not going to live through that. That's our assumption. We don't know that, but so the testing's all been done on raw virus on a surface. No one's ever really sneeze on this counter and let's keep testing, see how long it lives. We haven't done that, but so again, what we're being told is just clean your computer screen. Clean, if you're coming on to work that day and someone else uses your computer, wipe it down. Keep your cell phones wiped down. Wash your hands regularly. Just common sense stuff.
Okay. Yeah, it's interesting. I mean, I always kind of wondered about the cell phone thing, even before this. It's like, people go in the bathroom and they're playing around on their cell phones now, and you come out and you wash your hands, but you don't wash your cell phone.
Yeah, that's E. coli. It's different. That's a bacteria, or
different issue.
GI issues, fecal oral.
What about so we talk a lot about exposing people to each other. What about pets?
This is a virus that we found that highly suspicious it came from bats. That was we think that's where it came from. We don't know if there's an intermediary host. So an intermediary host would be like with typhoid would be your rat. Something that can cats. Everyone worries about cats. They can pick up different things and they poop and then they walk on your countertop and then they spread their feces. And then you touch wherever they were, the cat would be the intermediate host. They eat the mice, they process the mice, and then their feces, they spread it to you. So we don't know what the intermediate host is, if there is one. So theoretically, I guess your pet could become ill, but we just don't know yet.
We don't know. Okay. Yeah, no, I mean, I think about that in terms of being a pet owner, but also when we start talking about how we get this thing under control, if it could spread into birds or other wild animals or whatever, right? Then it's just, kind of out there.
Yeah.
What about incubation period? What do we know about that?
For the human, we're thinking it's the shortest incubation after exposure has been about 2 days, and the longest is about 11 to 12 days. Average is 5.5 days. If you're exposed within 5.5 days, you're going to start having symptoms. That's where the mean is for becoming symptomatic. But it can last as much as 12, so hence where the 14-day rule's coming in. So if you're exposed in 14 days, you should have either incubated out and now showing symptoms, or now you're okay.
Got it. And so what's known about when we're contagious or infectious during that period?
You're contagious before you're symptomatic. We know that kids are carriers. These young children can carry it and not even get sick when they're carrying the virus. We do know that once you become symptomatic, your viral load, or the amount of viruses that you would say cough out or sneeze out, is tremendously high. It just, as you become more symptomatic, you start shedding more virus. But once you've been exposed and your body starts processing the virus, your viral, it starts to infect you, you now are infectious. You can pass it on without even knowing it. And that's
without even knowing it. Right.
Mm-hmm.
In that period of time when you're infected, it's incubating, you're contagious. Mm-hmm. And then as you become symptomatic, you're potentially still contagious for a period of time. And then that tails off as your body's processing it.
Correct. We're learning that there are some people that, depending on the treatment modalities how sick they were and how they were treated, different medications they may have been exposed to, they may be long-term carriers. So we're learning now not to give steroids. That's the current recommendation to someone, where we'd normally treat someone with a pneumonia with some steroid to help them. We're learning that those people are becoming chronic carriers or long-term carriers, longer than we'd expect them to be. So that is a possibility.
Interesting. Okay. And so, I mean, a couple other things it seems like we're trying to manage here. So we're trying to manage the spread. We're trying to manage the rate of the impact on the healthcare system and the capacity to deal with that. And it seems like part of that is we're trying to manage the availability of testing right now. So how there's talk about this sort of triage or pre-diagnostic Google website. So how do people start to know or think about how this thing is different than the flu or colds, right? Because we're in the same cold and flu season that we get every year.
Yeah, that's a very good question because the symptoms are very similar. You really can't delineate if this is the COVID-19 or the regular flu or say the common cold or an allergy. Allergies, that's a little bit easier. Allergy is going to start out with the runny nose, your red eyes, your itchy throat. It's not sore throat. It's just regular allergy symptoms. You're not going to have a fever. You're just not going to have those more aggressive symptoms that you're going to have with either a viral infection or this COVID-19 virus. We know that when it hits, most people are going to have a fever. That can happen with other viral infections, say the flu or the cold. But the majority, overwhelming, most common serious symptom would be fever, and then cough and sore throat. So if you're starting to have the muscle aches, myalgias, so those are the symptoms we're looking for. And again, they're very similar to other viral illnesses. So if you start having those symptoms, we need you to call into either your physician's office, your personal physician's office, or different healthcare systems have set up numbers that you can call, 800 numbers, that will walk you through the process to see, number one, do you need to be tested? And then what to do next. Do you need to come in and be seen or not be seen? Because if you don't need to be seen, we don't want you in or around the healthcare system until there's something that we can do for you.
Right. Yeah, in both ways, right? Exposing yourself or vice versa. So cough and or fever are the biggest, sore throat and muscle aches potentially additionally. So I'm just reading this email I just got from my local emergency care facility, Doc in the Box here, and it seems like it describes sort of that same decision tree that you just mentioned. If So the first thing they're doing is administering a flu test, and if it's positive for flu, great, we treat that. If it's negative, but you still have a fever and or cough, then they've got a decision to make about whether they test you for COVID or not. And it seems like from what these guys are saying, they're going to make that decision based on you personally, what your risk, maybe, I don't know if it's risk for mortality or what risk assessment they're doing about whether or not they're going to administer the COVID test. So are we still at a massive shortage of ability to test?
From my understanding, we're limited on the numbers of tests we have. I don't know if I'd use the word massive shortage. What we're doing is we're triaging people, as you mentioned, into a triage tree or an algorithm that says, okay, this person we're going to test. What's determining in my area what's going to be tested? First of all, symptoms, what your symptoms are. Then we're going to ask, what's your travel, what's your risk of exposure? If you've been exposed to someone with the virus, if you haven't been exposed, if you traveled to that area, if you've been exposed to someone who's traveled into the areas where we know that are called quote unquote hot zones. And then we're testing a little bit more aggressively than just for the flu. We're running, in my area, we're running a complete virology screen for any upper respiratory tract infections.
Gotcha.
If that comes back positive, then we're assuming that that's what it is. The cold virus, the flu virus, the rhinoviruses, so if one of those show up, then we're assuming that's it and treat it like you just said. There have been some cases where very rarely does the COVID show up with other viruses, but it could. But again, that's why we're asking your history of possible exposure at this point. My guess is that will change as it becomes more prevalent in the community, that no longer that travel history or that exposure history is going to be relevant. But right now it is. So that's how we're doing it. And then so if you go down the decision tree and if everything's yes, then we'll test you for the COVID virus. But we want to do most of the triage over the phone before we have you come in. Hospital in I'm at, we actually have a drive-through testing. If you meet the criteria, they're going to test you right there. So that's kind of where we're at. I don't know what it's like in the rest of the country. So.
Okay. Yeah, no, that's great to know. So I mean, one thing I took away from there, I did not know that some areas are doing a call-in triage. So it sounds like people would want to check with their healthcare system, their healthcare provider in their area for how they're processing this.
Correct. That's the first thing you do is call your provider or call the hotline. Like, let's say if you got whatever your insurance company is, go to their hotline or even go to the CDC. They can put you through the triage, and you can figure out now, yes, I need to come in and be tested. No, I don't. Again, based on symptoms, it'll be based on your travel and your risk.
Bats, man. You say CDC, I'm just thinking fucking bats. Like the only time I've had to deal with a CDC before is when I got bitten by a bat and I had to get rabies vaccinations.
Yeah, no, yeah. But that's where we think it came from, is bats.
So there's a difference, I to my understanding, between exposure, contamination, and infection, right? So is it true that not everyone exposed will end up infected?
That's true. Yeah.
Okay. So yeah, just kind of realize that as I started thinking about some of the models I've seen on containment slash sort of avoidance. So let's sort of maybe move to that. I think we've all heard about this idea of flattening the curve, meaning slowing the spread, which I think is the overriding philosophy, but behind some of the things we're trying to implement in this country. Other countries are doing it differently. The UK seems to just be trying to sort of take their licks and let it spread and let our immune systems handle it. So
Yeah.
what's your take from what you know on how this fits together with an international travel ban? Is that sensible? Is it effective? I mean, the thing's already here.
Yeah. Is it effective? It's not effective if you look at a view from 10,000 feet. It's coming. It'll be here. It's going to be in our community, and it's highly contagious, and it will be spread. But it does help with how fast it enters the country. And what it's interesting, we haven't got enough information out, I think, to the people in the country, is why are we doing this? And the reason is our healthcare system is limited to the amount of patients that we can take care of. And so that's what we're talking about when we say flatten the curve. And you see a lot of things on Facebook. Well, I'll just go out and get exposed. We'll have a chickenpox party, and everyone will just get, like when I was kids, one kid had chickenpox to throw us all together. We'd all get chickenpox, and a week later we're back in school.
Right.
Not a good idea. Now you look back on it, but what you got to look at is that number we talked about earlier, that 2%, that 5% of people that are, that die from this. And those people are not easy to take care of. So when you have 80% of the population, and the articles I've been reading, are going to be okay. I mean, you're going to get it, you're going to get over it, you're going to be fine. It's when you expose it to people like the nursing home in Washington, what do you do? And when someone gets sick with this, they get something called ARDS, or it's a respiratory distress syndrome, where their lungs start to fill with fluid, and they can't move oxygen back and forth. The membranes become non-functional, and so at that point, then they have to go on a ventilator, and we only have so many ventilators. And so then you get into a position of, well, we're running out of ventilators, and now we ran out of ventilators, and then you're on your motorcycle, you go out and crash your motorcycle, you come in, you're now a trauma patient, you need a ventilator. We don't have a ventilator, sorry. That's now you start worrying about triage of who goes on the ventilator, one, who gets to stay on the ventilator if you have someone that comes in that needs a ventilator. And so these are decisions that nobody wants to make.
Right.
And so if we can control how the virus comes into the community, and we can slow that progression, and we can protect the people that are at highest risk for never getting the virus. So that's the thought. If we can prevent how quickly it spreads, that's what we're talking about, eating the curve, and protect those that won't get it, or that do get it, that can become very, very ill, and then we become inundated. It's interesting to watch human behavior. When you look at the stores and what people are buying, we were in the store yesterday, all the bread's gone, but you have all the cough syrup you need. And the people, It doesn't make sense to me that, I don't know why people are hoarding it. That doesn't make sense either. We can talk about that, but um, it's we need to just protect the older, because when they start showing up at our ER, people get sick and they just come to the hospital. They come to the hospital, they spread to everybody. Not only we're spreading it to everybody in the community, then the weaker, but then the healthcare providers get sick, and we only have so many of us around. And so that's why we're saying, okay, let's limit this, because when you do get sick, it's sick, and it's real deal. And these people are critical. I mean, granted, as you mentioned, 3 million. That's a lot of people on ventilators.
That's a lot of people. So
Yeah.
just one thing you said there, I think that there's a gap in my understanding on the numbers. So there'll be a percentage of people with anything that could be exposed and not get infected. And then of people infected, like you said, there will be children, people just with stronger immune systems. They will fight it off. They might feel bad. The range of symptoms will vary, and they'll fight it off. And then there'll be a percentage of those infected who are very seriously ill and
Correct.
really need some serious medical treatment. And then, we're talking about overall something so far that's averaging about 2% mortality rate. Do we know anything about the recovery rate of the people who come in with the serious illness that need something like a ventilator?
We don't. That's what we don't know, and I think that's why we're seeing the travel ban. That's why you're seeing people being, of those that get really, really sick. What is your survival rate? Again, it's going to be dependent on your health going into it. You can be. I have friends, as we were talking earlier, that are 60 years old and can run a 6-minute mile.
Yeah.
Then I got friends that are 40 that the thought of running a 15-minute mile is just not even in their wheelhouse. And so it's not just your chronological age in some respects, although the lungs do get weaker as we get older, regardless. But there's also this physiological age versus chronicle age that for those that take care of themselves are going to do better. And I think that's where your question is shooting at, is who are those people, and how many of those, what's the percentage of those people surviving if they do end on a ventilator? And I don't have that number for you today. It's changing all the time. So.
And so for people that do end up, let's say on a ventilator, some serious level of hospitalized care for this thing, is there a treatment, or is it a matter of trying to let the body have time to get healthy and fight it off?
That's a good question. Right now, technically, from the FDA, there is not a treatment. There is no FDA-approved treatment. There are some drugs out there that we're looking at. There's some anti-HIV drugs that we think might help. There's an antiviral out there that's in some clinical trials right now that we may think help. And then there's another drug that's really came out of nowhere, chloroquine, or hydroxychloroquine. It's a malaria drug. And it's interesting that certain countries are actually implementing that drug. One of those countries was Japan. And so are the Japanese numbers better because they had a younger age population get infected, or are those numbers because they were using this drug? And this drug works really kind of cool how it works in the cell. It actually increases zinc stores within the cell. If there's a lot of zinc within the intracellular matrix of your cells, and the virus tries to come in, it can't replicate because the zinc prevents it from replicating. So there's no clinical evidence that we have, statistically, that shows that drug works, although we do have some anecdotal evidence we're seeing in some studies now that it might work and might help. And it has worked with other coronaviruses in the past. So there are places outside the United States that are currently using it and anecdotally seeing some success. So that might, to answer your question, that might be one of the drugs that we use that we're looking into.
So the things like that are getting explored. That one in particular, I mean, is there a downside to it? Is there a risk to that treatment?
It's a drug that we use quite frequently for rheumatological issues. Lupus is one of them. We use it with our lupus patients in pregnancy. It's a drug that if you were to go to Africa, they would put you on. It's an anti-malarial drug. So you would take 1 pill a day or 1 pill a week, a couple weeks before you go, and then you just take it while you're there. So it's got a long-term safety record, but yeah, there are some risks to the drug. One of them is if you have certain cardiac arrhythmias, if you take it, it can put you into a lethal cardiac arrhythmia. So your doctor needs to know your history and what's going on, and you just can't, buy it off the street and start taking it. There's some, you got to be worked up by a physician to make sure it's safe for you. But
yeah, I mean, you guys have a very complicated job. Every patient is obviously a little different. Maybe if I want to springboard from the zinc to maybe some other things that we might do just preventatively for health. But before that, it just made me think about, and let's talk about the hoarding stuff in a few minutes too. But just supply chain for medicine and other supplies that you guys use. So, for example, I don't know if this is true or not, but I heard or read somewhere recently that the crash cart drugs that you guys would use in an emergency room are largely generic and manufactured now in China, right? So if the global impact of this thing starts to shut down supply chains of different sorts, have you guys seen or do you have any concern about the supply chain for hospital supplies and medicine?
currently, that is the theory that we could see that. The answer is in theory we could. It's not just those types of drugs. Long before we saw this virus outbreak or this epidemic, pandemic. Now that we're seeing, we had drug shortages of all kinds of drugs. I mean, doxycycline is a basic antibiotic. It's cheaply made here in the United States. We had shortage of that. So that's not new to us. So I guess when you look at supply chain and could that disrupt the supply chain? Yes, it could. But those drugs, I guess we could make them here in the United States pretty easily if we needed to. It's just going to be a cost issue, from my understanding. I know that there's current antihypertensive drugs or drugs that treat hypertension that, at least in my area, there's been some generic uptake companies and just started making it. So it didn't take very long to get that up and going. But you're right, that could be a theoretical concern as our supply chain thins down. And if we can't get them from China, I guess, I'd agree that could be a concern. But right now we're not. That's on our radar of worries, but it's not a concern today as of our discussion right now.
Yeah. All right. Thanks. And obviously can't predict what's going to happen, but good to know that that's a type of manufacturing we've seen spun up in the past. I mean, you think about something like auto manufacturing largely going overseas. It's not as easy just to get that back up and running. Okay. So zinc, and maybe this is a different type of zinc, but I know I've seen zinc products that are potentially taken to reduce the time that you're affected by the seasonal cold, right? There's all these zinc stuff over the counter, vitamin C. I've read stuff about B1, which I think's thiamine. Mm-hmm. Vitamin D. I think even when our son was an infant, or maybe not an infant, but at a young age, his doctor recommended D supplements for boosting the immune system, or we just get outside, right, and get some sun and make vitamin D ourselves. What kind of things like that are just sort of good proactive medicine, if you will, for our health?
Vitamin C is always, the nice thing about vitamin C, it's water soluble. So if you take too much, it'll give you a nice run of diarrhea, or your kidneys will get rid of it. I mean, it would be really hard to overdose on vitamin C. So 1,000 milligrams a day. Not going to hurt anybody and only going to help. Unless, there's really no downside to vitamin C. Zinc, we know that zinc the zinc lozenges can be a little bit of protective in the mucus. They can protect how the virus penetrates mucus. That's kind of how we think it works. But again, how zinc works, it needs to be effective, like the drugs we were talking about, it needs to be in the cell. So that's where these drugs become effective. So I think zinc, again, not a bad idea to take a normal zinc supplement. Not going to hurt anything. Might help. Other things are things that you and I do every day. Get up, have a routine, eat healthy food, fresh water, hydrate, antioxidants, healthy diet, exercise. I can't, emphasize enough a healthy lifestyle. Wash your hands, regularly. It's basic common sense. you
Just
know?
good practice.
Yeah.
Yeah, I went to the grocery store the other night, and like you said, the bread aisle is gone. Like all this processed sugar basically has sold. There were heaps of fresh vegetables, organic and
Right.
conventional. So I had my run on the produce aisle, no problem.
Yeah, we can talk about that if you want. I'm not quite sure why people feel we need so much hoarding. I get it if you're going to be quarantined to your home, but I mean, just think about, just look what's going on today, just in the world. I mean, if you want to order out from a takeout, they're still allowing restaurants in San Francisco to either you drive by, pick up, or they bring it to your house. So if the restaurants are getting food, the supply chain's intact. But the problem is when you stress the supply chain like we've done, it's only so much they can keep bringing to you, and they have projection models of how much they're going to make of this or that. And once it's gone, then we're going to have to speed up production. And some products we can do that very well, and other products we can't. But I take away what you said. Yeah, our vegetable aisle was really nice, with the exception of potatoes and onions. And if you don't have a root cellar for those not to go bad, I don't know how much you got 100 pounds potato in your kitchen. It's not going to help you. It was also interesting to me. I walked down the baking aisle, and all the flour was gone, but there was plenty of salt, there was plenty of oil, and there was plenty of yeast. So for those that, what are you going to do with all that flour if you can't make bread, if you can't make pancake batter, if you can't make whatever you're going to make, pizza dough, I don't know, whatever they're thinking they're going to make out of that flour, you need basic other ingredients to make it. So again, you go to the pharmacy aisle, and there's all the cough syrup and the Tylenol and the Motrin, and everyone's and then the water thing. I still, this does not affect our water supply. Water supply for the United States, for most part, would be safe. So hoarding all that water is really, it's not an earthquake, it's not a flood, it's not a hurricane. That doesn't make sense. Toilet paper still doesn't make sense to me. Everyone's hoarding toilet paper. Yeah, if you're going to be sequestered, at max it's going to be 14 days. And even still, even in San Francisco, where they've locked the city down, they're still allowed to go and do some shopping. So again, it doesn't make sense to hoard all this stuff where people are now going without. I have a patient who needs some formula for her baby. It's a special formula that she can buy at Walmart, and that's it. It's gone. She can't feed her baby now. So I'm not, the hoarding thing, I haven't put why are people feeling like they got to buy, we have people here in my town buying extra freezers and filling it with meat. This isn't the apocalypse. We're just going to get through it like anything else. I'm not quite sure. Maybe you can help me understand that.
Yeah, I mean, I don't know if I've got an answer indicative of the extreme, or even an insight on it, but I guess a couple of things that come to my mind would be that getting through something like this with calm and cooperation takes some leadership. And in my own opinion, we don't have strong, decisive leadership over the country on this matter right now. There's a lot of waffling, and I get that it's a volatile environment and there's new information every day. But the policies and what's projected and what's spoken about seem to swing. And so I think there is a concern of, what is coming. So it's close the national borders. Do we sequester regional or state level travel? Do we eventually just order everyone sequestered? And so, if something like that becomes necessary or is possible, I guess my question, and maybe people have the same question or concern, is if you take that to an extreme, do you sequester everybody, right? So does that literally shut down your restaurants, your grocery, I don't know, your water, your sewer, your trash, your critical infrastructure for 14 days? So do people need to be prepared for at least 14, and are they thinking beyond that? So that's where I think the mentality may come from.
Well, I get that. I guess there's going to come a point where shutting things down is no longer going to help. I mean, if you just think about it, once the virus is here in a certain concentration, it's here. And so shutting things down really isn't going to help per se, because of the volume of disease is here. Again, what we're trying to prevent is those that are going to be the sickest from inundating the healthcare system. So the people that we probably should be most worried about and sequestering most aggressively would be anybody over 60, anybody with health issues, anybody that is at risk for dying, or those are the people we need to protect. So if I was going to sequester anybody, it'd be them. I'd say, look, yeah, you guys, we're going to put you someplace safe. You have to follow these parameters. But yeah, I don't. Yeah. Anyway, I see it kind of like you do. We need a little bit more leadership, calming leadership. Look, it's going to be okay. The majority of us are going to get through this. We're going to be okay. Unless there's something that I don't know about right now. I mean, I just can't. That's just what I think is going to happen. We'll be fine. And you're right. We should all. If I looked at what do we need right now, everyone should probably have a 1 meal a day for 14 days for each person in your household. That's pretty basic. I think we all can have that for home. Medicine wise, probably some Tylenol, cough suppressants. There's been some reports about Motrin in this disease. I don't know how to advise you there, but again, it's a good antipyretic or an anti-fever medication. So check with your doctor before you would take that. If you have asthma, I'd have an extra asthma inhaler. If you have chronic medications, I'd have a 30 to 60-day supply of your chronic medications. And then as far as food goes, bread's going to last you a couple of days. Fresh, like we were talking about the potatoes and the onions, that can all go bad, spoil on you. So I kind of take the Chopped Champion approach to shopping. If you ever watch Chopped, I just kind of, when I go shopping, I look at, because I'm a chef, it's my hobby. I think, what 5 things can I make out of this one ingredient? So I want basic ingredients. I'd want beans. I'd want rice. I want like the flour, but again, I'd get the stuff to buy bread, like oil and salt and seasoning, pepper, that sort of thing. So I can take one raw product and make several meals out of it.
Right.
Dry milk would be something nice to have. That's the mentality I think we should have. And then buy stuff that you would normally eat. So once you have your 14-day supply, keep a good inventory. And then as you deplenish your supply, go out each week and buy what you used, and maybe just a percentage more, 5 or maybe 10% more, until you have a little bit more supply in your home. That way you're not inundating the supply chain and then they can't keep up with the demand. It's basic stuff. People that grew up under, I grew up in the Mormon culture, and we were taught to keep a 2-year supply. I think that's a little aggressive, but I think if you have a 14-day supply on hand, and then you slowly add to that over the next several weeks to months, you get up to a month supply over a long period of time, that makes sense, and then if someone needs help, you're able to share with them. So.
Right. Yeah, I definitely get having some cushion. I don't get the humanity of fighting over stacks and stacks of toilet paper from Costco or wherever.
Yeah, and hand sanitizer.
Hand sanitizer.
That actually is good, but washing your hands is better. That's just wash your hands frequently. I've heard reports you can make your own hand sanitizer out of isopropyl alcohol, and then everyone out about isopropyl alcohol. Well, it has to be at least a 60% concentration to work. So once you start diluting down your isopropyl alcohol, it may not be effective with that. But I guess there's some that have mentioned you could buy a bottle of Everclear, which is a 190 proof. Very inexpensive, but again, it makes sense.
Then you make punch out of it, right?
Yeah. Then when this is all over, we can make punch. If it really goes down, and then we can make some punch.
That's like a hurricane party. What about? I don't know if you have the answer on this, but you mentioned prescriptions and making sure you have your prescription on hand. If you've got something that runs on a rotating 30-day refill, are doctors able to extend that to 60 days now, or some consideration like that?
We are, yes. It's the pharmacy that's limited by your insurance plan that is not.
Got it.
We can write for 90-day supply, 120-day supply. It's the insurance company that's reimbursing the pharmacist that tells them how many they can give you. I talked to a pharmacist last week, and with an initial prescription, say for hypertensive medication, they have to give you 30 days when you go back to refill it, then they can give you 90 days based on particular insurers. If you're on a very inexpensive, ask the pharmacist what the cash price is if they're not going to give you a 90-day supply. I mean,
Right.
some medicines are very reasonable, and generic is, you can afford a 90-day supply. And then there's that are like, well, that's my inheritance plus that, I mean,
Right.
in the trust fund to pay for it. But yeah, you can ask the pharmacist to help you do that. And
Yeah, that's good to know. I didn't realize it was more limited by the insurance reimbursement, and I had not thought about the cash thing before. I don't remember what it was last time I got a prescription for something. I think I tore myself up at a Spartan race when I broke my finger and split it open and got an antibiotic. And I'm standing there forever at the pharmacy while they're trying to look up my insurance, to be able to charge me $15 for this thing. And finally, I was like, dude, I got to get out of here. What's the cash price? And they're like, oh, $5. Like, why didn't you tell me that in the first place? Could have saved $10 and the last half an hour of our lives.
that's true. So, but they're supposed to give you the cheaper of the two. So, I mean, that.
Yeah.
Anyway.
Okay. So beyond some of the stuff we already talked about, what else can we help do for you guys as medical professionals? So one specific question, and then open it up to your general answer. When there was still a consideration on closing schools,
Mm-hmm.
I heard a statistic that something like 40% of nurses have children who are in schools and may not have alternative daycare. And so having children out of school, schools canceled, nurses may have to stay home, can't be at the hospital or otherwise treating patients. So, if you've got a friend who's a nurse and they got a kid you can help out with, get the nurse back to work, other things like that we can do as a community to help the system, the healthcare system.
Well, those are all excellent points. Yeah, I have several nurses that are in that boat that I work with. It's not just nurses, it's doctors have kids that end up in school, end up at home. Or what's even more important at the hospital, that's not just doctors and nurses, it's the person that cleans the room.
There you go. Yeah.
I mean, they're just as valuable as we are. They have to clean the room, or the guy that cleans the floors, or the person that cooks the meal, or they're all just as valuable as I am in this care provider chain. So things we can do is reach out through community groups. I know there's church groups and things. Where I work, we have a daycare for the nurses, so that they can bring their kids to the daycare there. So those are things that we can do to help each other out and offer, those types of things. Then we have elderly care. We have nurses that have parents that are living with them. And then what do you do with that person? Do you want a nurse that's working around this virus to come home and take care of their parent that potentially could die from this virus? So then we're having people deal with those issues. So they need help with elderly care. So these are all, you bring up some very good points that I don't have answers for. But again, it's kind of like, you're raising a kid. It takes a tribe to raise a kid. It's going to take a tribe. It's going to take a tribal mentality to get through this and help each other instead of.
Yeah, no, those are all great points about how valuable everybody is equally in making this thing run and getting through it as a community, coming out the other side of this, hopefully even better and stronger than before. And I want to ask you about that, but one more quick one before we do. So maybe it's a dumb question, but we talked about takeout food, we talked about the water supply, and I was just talking to my wife and my son yesterday, like, hey, look, let's make a point of ordering takeout a couple times a week from our favorite sushi place or the local business up the street, and try to help support them so that they get through this and they're there at the other side of it when we want to go dine in and eat again, right? But should I be worried that somebody sneezed on my pizza or in the water tank and it comes out the pipes at my house and I get it that way?
I'm not so worried about the water. Most of our water supply, it's a safe water supply. It's not.
Is that because it's chlorinated?
Yeah, we got chlorinated water. It's processed. It's if you're that worried, there's some filters you can buy that will filter out viruses. They're a little bit more expensive, but you can get viral grade filters and filter your water. Or if you're really freaked out about it, boil it. I mean, again, the water thing that I don't understand. I mean, like I said, there's several ways to approach that than just go buying pallets of water. Hurricane, earthquake, flood, that's a little different, right? Because now we know the water supply is probably contaminated, and then we have to do things.
Prepared
So
foods.
as far as eating out, again, I guess you just have to have faith that the person that's preparing your food is not sick. And if they are, then potentially if they touch your food, they could get you sick. Cough on your food or whatever. I mean, yeah, I guess that's in theory a possibility. I mean, so I guess eat at your own risk. But I also agree with supporting the local economy. There are things that we're doing here. We are buying gift cards from your favorite restaurant and then giving those out, or for yourself. If you're used to buying out a meal every week, buy that meal and a gift card. That way the restaurant owner has that money now to help offset whatever costs they have, say rent or whatever that they're gonna have to pay because money isn't coming in. And then now you can come in and use that gift card in 3 weeks, 6 weeks, a month, whatever, when we can start being mobile again. I think that's a good way to help people. So those are my thoughts. I guess anyway.
Yeah, no, that's a great idea. I hadn't thought of gift cards. I like that one. What about, so I just popped open Facebook earlier to get in touch with you, and I see an ad for the Air Doctor home air purification system. Do you have any idea if those kind of things are effective against virus?
I don't have any knowledge of that. I have to punt to
Right,
maybe.
punt.
I don't know.
All right.
I know good filters are good. You want good filters in your home, but again, yeah.
Yeah, I mean, I think the idea is they've got HEPA filters or whatever, which I'm getting emails from my airlines saying, "Don't worry, we have hospital grade HEPA filters on our airplanes." Which I hope that's not true, and that you guys have better air filters in the hospitals, because we all get sick on planes like in a good year, right?
Well, it's interesting that I've been learning, because we're dealing with this, and most hospitals in the United States, they change their airflow 12 times an hour. So yeah, it's, again, you're asking a question assuming that you have the virus in your home. If you don't have the virus in your home, then none of these are going to, again, it's about, like you asked me the question, exposure versus, contaminated versus whatever. The virus has to be there for you to get it.
Yeah, good point.
And so if someone in your home does have the virus, then they need to wear a mask. If you're within 6 feet of them and caring for them, you should wear a mask. Anything that they touch or breathe on needs to be washed. Surfaces, phones, bedding, clothes, because it can live on clothes, and that's why we're not hugging anymore, because you can cough and sneeze and then hug somebody and then transfer the virus that way. So once someone ends up in your home that's sick, you have to take different precautions. So I don't know how much this high tech would actually help. Might help have a nice cleaner air in your home, but as far as viral protection, probably not.
Okay. All right. Well, look, I don't want to take too much more of your time, but we got to hit the positive side of this. So, what are some ways that we come out of this better and stronger afterwards, as individuals, health wise, as a community, as a world?
Let's start with health-wise. I think health-wise, it's kind of brought an awareness to something you and I have been working on a lot. And that's being healthier, more active, taking care of yourself, being more prepared. So I think maybe kind of gives us a little religion for those that are a little bit not as healthy. It's kind of a wake-up call. I should be healthy. I think that's a very positive. I think it makes us look at, not the junk food anymore. When you go through you go shop at Smith's or Albertsons and Kroger, that now I'm going to have to buy fruits and vegetables. So I think that's a positive. I think it's a positive. It's going to make us come together as a country and work as a team again. We haven't done that in a while. I think that's, kind of like a 9/11, but bigger. We're really realizing now what our priorities are, and our priorities really should be our family and taking care of each other. And I think that's a huge positive when we start no longer thinking of ourselves and thinking of our neighbor and our friends and all the stuff that you and I have been working on through all this training and how we met. I think that's a huge positive. So hopefully maybe that will help change how we look at things and how we do things in this world, and maybe being a little bit more prepared. I mean, we all really, when this comes and goes, maybe it'll make us reflect and say, I really should have a 14-day supply of food that I rotate through over monthly. Maybe I should have a little bit of first aid training. Maybe I should understand medications a little bit better. It just makes us more aware of what we're doing and what we're going.
Yeah, absolutely. I think that the Great Depression generation in this country, and other countries have dealt with massive impacts or wars. If you remember, your parents or your grandparents from that generation, they had a little bit different mentality. And I would hope that in a first world country, my son never had to see grocery shelves empty, and concern about where the food was coming from, or is it going to be there. But at the same time, it's a great wake up call. I love your point about kind of coming together again as a country. And I think we're a country and we're a world, and we're humanity are we have a drive to innovate. We have a drive to solve problems, and I think this is just going to expose opportunity for innovation, whether it's in the healthcare system, whether we do some things from a supply chain perspective, what we do as a community, tools for all these people working remote now. That's going to stress technology. We'll come out with better technology. And I hope we come out with a better, as you said, awareness on diet and physical health. And maybe we wrap it up with, the other thing you and I have been working on a lot, which is mindset and the mental side of staying healthy through this as well. We're pack animals. We are social creatures. So to the extent we've got to, kind of sequester, that's tough, right? So, and stress will bring down your immune system. So, is that something you share with your patients or your coaching clients as far as the mindset to get through this thing?
Yeah, I do. With not only my coaching clients, but before I did this coaching program with you, I was with my patients. I worked a lot of work with, meditation, breathing, exercise, diet, holistic approach. I'm an osteopath, so for me to I'm trained in that holistic approach of medicine, physical medicine as well as the surgical and the medical and, pharmacy. And so for me, so my biggest takeaways from this is, number one, the butterfly effect is probably the biggest thing I'm taking away from this. And, the butterfly effect is when a butterfly, moves its wings in New York, it can affect the winds in China, and when you look at the world that way, what you personally do in your life, as we've been taught, what you do at home in your private really reflects on who you really are out in the world. It's what you do in private that defines who you are. And so we are all responsible for what we do, and we just need to, number one, take care of ourselves, health-wise, mentally, spiritually, emotionally, and then take care of others. And so my takeaway from this is take care of yourself, take care of your family, wash your hands. If you're sick, be responsible. Don't go to work. Try not to expose other people, and just don't panic. Don't go out and clean the shelves. Go out and buy what you need, and then help your neighbor when you need to. And then just have faith that our supply chain is the best in the world, and we're going to be fine. But that's just my takeaway. Just take care of yourself, be healthy, and don't forget to wash your hands.
That's awesome. No, I really appreciate it. One of the things to maybe wrap that up that I know you and I have heard from Mark and the other coaches we work with is VUCA. It is a volatile, uncertain, complex, and ambiguous world, and this is this is a pandemic. It's massive, but we will come through this. We'll come through it overall in better shape, and it won't be the last time that we're challenged in our personal lives as a community, as a global community. So definitely things to take away from this, and take the time and the opportunity to instill new practices, get healthy, spend time with our families.
Yep. Amen.
Amen to that. All right, brother. Well, thank you for humoring my questions and filling me in where you could. I appreciate the insight. I think people have a lot of questions, hoping to share this and maybe answer some of those.
I appreciate it. Thank you.
All right. Thank you again to Dr. John Nichols for taking time to share that information. If you're like me, the knowledge is somewhat helpful and comforting, even to know what we don't know. And this one was just a great reminder to get back to some very simple lifestyle things and staying healthy physically, mentally and as families and communities to get through this thing and come out the other side stronger, wiser, and closer than ever before. So as we move forward, I will reach back out to Dr. Nichols if we want to get him back with further questions and as the situation evolves. But until then and back to this week's regular schedule, I certainly hope that we get through this thing quickly and that you and your loved ones stay safe and healthy.